Yeah, that's that is oops. Yeah, it's the what I call SPS model in English, SPZ in German. Emotions between structures, problems, and states. Basically, it is. Why doesn't it work? Oh yeah. Yeah. For the next somewhat 10-15 minutes, I want to talk about diseases, diagnoses, structures, and problems. And these are thoughts that arose in the context of my focus on autism primarily, and about the theory of diseases in general. So as doctors and psychologists, we want to make diagnoses, and often we think when we've made a diagnosis that we have kind of clarified a special feature, but it's not so clear what diagnoses are at the end of the day. And in everyday life, in medicine and psychology, we work with very different concepts of diagnoses. The strongest concept of diagnosis is the etiological true diagnosis. An example would be neurosyphilis. And this is the kind of medical diagnosis where the term refers to the first cause of the condition. Like, for example, in neurosyphilis, it's an infection with Treponema pallidum, and that's causing all the symptoms and signs and the cause of the disease. That's the only true concept of a disease. The disease in its strong definition is only given if you have such an etiological first cause. But of course, we do have other disease concepts. For example, epilepsy. In epilepsy, the term also refers to causal elements. For example, the firing of networks, the dysfunctional firing of networks of neurons, what we call the pattern mechanism. But it's not the first cause, because, for example, you could have epilepsy because you have a bleed to your brain. You could have epilepsy because you have a tumor in your brain. You could have epilepsy because you have a stroke or whatever. And then, and that's the case in psychiatry most of the time, you have syndromal diagnoses, where the diagnosis is only a collection of symptoms and durations. And that's the case, for example, with depression, psychosis, ADHD, and autism. So in psychiatry, we don't make causal diagnoses, and that's of relevance when we come to talk about the SPS model. I come back to that later. It's also interesting to think about the word diagnosis. Like, what does it mean at all? When maybe 10 years ago, I thought diagnosis is the way how you come to an etiological identification of a disease, but that is, of course, only the case in a minority of given cases. In fact, diagnosis means to look through. Gnosis, the Greek word, means knowledge or judgment, and dia means through. So to come to a diagnosis means to come to a valid, to look through the complex mixture of problems, symptoms, states, and what have you when you are confronted with a patient, and to kind of clarify and to sort out what this complex mixture of different phenomena really is constructed by. For that purpose, I use this SPS model for now somewhat 3 years, more or less. In this model, S stands for structure, and structure means phenomena like personality disorders, autism, ADHD, IQ, or body height. So when we are confronted with patients, they have structural specificities, and you cannot change these structural specificities. This is easy to understand when you think about body height. If you have a person who is 210 centimeters tall, then it's a giant. And this is very relevant for the life of this person. Maybe he's being mocked because he's a giant, but you cannot change the structure. And the same is true with autism. When you are suffering from autism, then, for example, you have a sensory oversensitivity. You're very sensitive with hearing. You're very sensitive with specific optical features. You're very sensitive to slight touch. You cannot understand what other people have in their mind because you don't have the theory of mind. And all these psychological features are also, in most of the cases, should be understood as structural phenomena, like body height. You cannot change it. And the same is true, for example, with your IQ. IQ is more or less a talent. It's a fate. You get it, and you have to live with it. And the same is true with other personality structures, like, for example, in patients with ADHD. Then you have, as a consequence of your structure, very typical problems. For example, if you think of your patients with autism, they behave odd, they withdraw from other people, they are loners at school, at kindergarten, maybe at university, and then they are regarded as arrogant. For example, the pattern that autistic people, if they are high functioning, are regarded as arrogant by others and are being mobbed by others is a very typical problem, but it's not a structure. Not all people with autism are being mobbed or picked at, but it's a fairly typical consequence, problem behavior that you see in people with autism. And then you have the third pole, that's the state. The states are medical states, like, for example, depression, psychosis, panic attacks. And I will come back to this in a minute. So what are the typical structural phenomena, for example, in people with autism? Take the sensory overload. It's a structural phenomenon. It's like having pain. You cannot change it. You are sensitive to loud noises, to overload situations, and you cannot change it. You can only live with it. The psychomotor agitation, the tension states at the receptive side, again, are structures because you cannot change it. The problems with cognitive empathy, with the deficient theory of mind, with alexithymia, we talked about that a minute ago. The communication problems, the need for routines, the rigidity, all these features are structural features which you cannot change. You can only accept and adapt to these features. And a few years later, I realized that this is the case not only with autism, but basically with almost all personality structures. Here are the personality features of the big five: conscientiousness, agreeableness, neuroticism, openness, and extroversion. If you think of your dear people, your wife, your husband, your friend, whatever, you will know them pretty well, and you can characterize them also pretty well. And you know this person is a rather impulsive person, or the other person is a rather withdrawn person, or the other person is a rather calm person. He or she is always calm, and the next person is very emotionally unstable. All these features are like autistic features or like body height, structural features. That's the way this person is built, and that's fate. Coming to problems, once again, what does it mean, problem? Problem is a Greek word, problema is the original word, and it means the submitted task. I think this translation is quite interesting. So according to Wikipedia, a problem is a task or issue which is difficult to solve. Problems are obstacles that must be overcome or circumvented in order to get from an unsatisfactory initial situation to a more satisfactory target situation. And exactly that's what happens in typical patterns with structures and problems. Typical structures lead to typical problems. For example, take the autistic person. The sensory overload is a structure, but this typically leads to a situation where an autistic person would withdraw socially from other people. They avoid going out, they avoid being in groups, they avoid going to parties. Tension states, for example, are structures. It's like a pain, you cannot change it. But tantrums, that you start shouting, biting, spitting, complaining, that of course is not a structure, that's a problem behavior. it's a problem because it's not essentially linked to the fact that you're an autistic people. It's common in autistic people, but that doesn't mean it's a structure. Cognitive empathy, the problem with theory of mind, is a structure or talent, if you want so. But an antagonistic communication pattern, which you often see in people with autism, is not a structure. It's a learned behavioral pattern, which is often dysfunctional. And it's very important to distinguish the structural element from the problematic element, because the structure you want to accept, but the problem you want to solve. And for that reason, it's important to distinguish structure from problems. And alexithymia, we talked about that in a minute. Now, coming to states, I personally realized the relevance of states in the context of this model when I had a patient whom I gave the diagnosis of autism and depression. And then I admitted this patient to my ward and we treated the depression. He was a very high functioning autistic person. He was studying and quite intelligent. And then once the depression was solved and remitted, I started wondering, oh, why did you give the diagnosis of autism to this person? The autistic personality structure was still well recognizable, but the extent to which this person was autistic was so much less than compared to the situation when he was depressed that I really wondered whether it had been a good idea to give the diagnosis to this person. And that was the time when I realized that the state of depression increases the severity of the autistic features. So autistic people who are stressed or in a depressed mode are even more autistic than they are normally. They are even more sensitive to overload. They are even less capable in recognizing other people's intention. They are even more reliant on routines, and they get even easier attention states and rage attacks. And once the depression is gone or the stress state is gone, then this extra more of being autistic goes away to the baseline level of being autistic. And then I realized that's the same not only with autistic features, but with all personality features. Think, for example, assume somebody in the audience has a very mistrustful friend. And if this friend is stressed or depressed, he's getting even more mistrustful, even more suspicious. Or the other person who has traits, maybe OCD traits, if you have OCD traits, which I would consider as a structure as well, if you're stressed or depressed, then the controlling behavior, the checking behavior gets worse. Or if you are a say, anxious, avoidant person and you're distressed or depressed, then you're even more anxious and even more avoidant. And once the depression is gone, this extra severity of avoidance, anxiety fades back to the basic structural level. And I think it's really important to recognize that, because this extra autism, which is induced by depression, even though the features are autistic, should not be attributed to the structural pole, but they should be attributed to the state pole. States do have a beginning and an end. Structures don't have an end. Structures are there like body height. They are there all the time. States do have a beginning and an end, and problems are behaviors that should be solved. So this is the psychodynamic of the SPS model, classically observable in people with autism. For example, the autistic person who gets, based on the specificities of the autistic personality, gets fairly typical problems with the colleagues at work, problems with the friends, if there are friends at all, social isolation, social withdrawal. These are the typical problems arising from the autistic structure, and the problems typically result in typical states, for example, depression. And if then the person is depressed, the autistic structure gets worse. And this, of course, is a vicious circus where the structure induces problems, the problem induces states like depression or stressed states, and the states again worsen the structural features. Why is this important? Why is it important at all to kind of sort out the mixture of phenomena according to this model? Well, it is important because it does have therapeutic implications. If you deal with structural phenomena, the person, your patient, is non-free. And if at all, that's an interesting question. Can you change structures in the psychological dimension? We might discuss it at the end. I think you might be able to change it a little bit, but if at all, only very slow. In the problem pole, people are predominantly free, and that's where you can change most in the psychotherapeutic domain. And in the pole of the states, of course, you are unfree, and respectively, you have different therapeutic implications. Structures you should not aim to change, but you should adjust, compensate, and accept. For example, if you have an autistic patient, you should not say, well, we make psychotherapy, and after psychotherapy, you're less autistic. That's impossible. That's as if you would make psychotherapy with a very tall person and promise that at the end of the psychotherapy is not 2.10 meters, but 2 meters. And that, of course, will not be the case. Problems you have to solve, and medical states you have to cure. So why is it relevant? Again, for everyday diagnostic and therapeutic purposes. It is relevant because if you don't recognize the structure, for example, you don't recognize the autistic feature as a structural phenomenon, then you tell to your boy, stop being so tall, or boy, stop being so autistic. Of course, that's impossible because that's the way he is or she is. And the only thing you do when you make a structural feature to a therapy goal is that you hinder the self-acceptance of your patient. If a state is not recognized, for example, a depressed state, and you mistake the autistic feature for a structural phenomenon, but in fact, this extra bit of being autistic is due to depression, then you don't treat the depression and you accept a phenomenon which could be changed, which could be treated, for example, with antidepressant drugs. And if you mistake a problem for a structure, for example, if you think social withdrawal is a structural autistic feature, then you accept that your patient withdraws socially. But that's not the case. I mean, he could change this behavior. It's not a structural phenomenon, but it's a problem behavior or a problem. And problems should be solved. And with that, I come to the final slides of this second presentation. I like to compare life and my patients and us all basically to an orchestra. It's a metaphorical model, the Orchestra of Life. And you could compare the instruments to the personality structures of human beings. And in an orchestra, you have different instrument types. You have the strings, you have the trombones, you have the, I don't know the English word, the instruments, the horns, the saxophones, the trumpets, you have the violins, you have the flutes, and you can recognize specific patterns within the variety of different instruments. And in order to know how you yourself or your patient functions, you must know what kind of instrument he or she is. Is he more a trumpet, or is he more a violin, or is he more a flute? So if you don't recognize the structural specificities of your patient or yourself or your partner, or whatever, your kid, then you don't realize and understand the kind of music this person might play, metaphorically speaking, in his or her life. And with that final metaphor, I come back to my concluding remarks. What has this to do with emotion? How is this topic of the SPS model at all related to the topic of emotions? Now, I think emotional arousal states, for example, are state phenomena. You cannot easily change it. No, sorry. I meant structural phenomena. So the vulnerability to develop emotional arousal states, for example, the phenomenon impulsivity, is surely a structural phenomenon. The state itself, a rage attack, is a state, not a structure, but the vulnerability to develop rage attacks is a structural phenomenon. You cannot easily change it. You should accept it, adapt, and compensate. And that's the typical problem for people with an ADHD-like or autism-like personality. Emotional behaviors, for example, rage attacks, on the other hand, as I mentioned before, is not a structure. It's a problem behavior, and you should try to solve it or the problem. Emotional states like depression are medical conditions. You cannot intentionally end it, like pain states, and you should try to treat and cure these states. And of course, you should try to not mix the different phenomena with each other, because then you end up in a situation where you accept things that should not be accepted, or you try to change things like structures that cannot be changed, and that is not helpful for your patient and also not helpful for your therapy plan. And with that, I'm at the end of my presentation, and thank you for your attention.
Thank you, Ludger, for a very clear and very thought-provoking discussion. You were talking about structure, so I want to take you back to, perhaps you could stop sharing your, yes. Yeah. I want to take you back to the time when you were interested in structure in a different way. I remember you being very excited by all these large amygdalas in people with epilepsy and various comorbidities, in depression and anxiety and in psychosis of epilepsy. Now thinking back, what do you think is the relevance of those large amygdalas, perhaps more on the right side? Why do you think you had those findings? How are they relevant to our understanding of the emotional brain?
Yeah, it's an interesting topic. I mean, it relates a little bit to my recent focus on immunological causes of mental diseases like psychosis, but also depression. Nowadays, I think it might at the end well have been subtle inflammation that took place in these nuclei. When I came back from London, I was invited by a colleague of mine, Karl Bechter, and he invited me and wanted me to talk. He wanted to interpret the enlarged amygdala as inflamed amygdala. At that time, I didn't believe him. I thought that's too concretistic to think of the enlarged amygdala as subtly inflamed amygdala. Now, somewhat 15 years later, with many experiences with patients where we increasingly treat with cortisone our patients with sometimes amazing effects, I start thinking, well, maybe Karl was right in thinking that it was structurally an altered structure due to very subtle inflammatory processes. But at that time, we didn't look at the other features so specifically. Today, when we think about inflammation, we always do a CSF study, and we look for autoantibodies and other inflammatory proteins in the CSF. And we have, for example, in our psychotic patients, in 5 to 10%, we do find relevant abnormalities. We still don't know exactly what it means, but it's not that rare. 5 to 10% is not that rare, I think. So maybe it's a subtly inflamed amygdala.
So which could well mean, therefore, it is state rather than trait. It could reverse itself over a period of time if you did follow-up studies.
Absolutely. I mean, with the SPS model, I mean, it is not always easy to clearly say, is this a is it a structural effect? I mean, trait would be structure and state would be state, and problem is more behavior. It's not always easy to clearly say, is this specific symptom a structure or a problem behavior? But the model, at least in psychotherapeutic processes, it often helps to discuss it with the patient, because the patients themselves often are not really clear about whether the phenomenon itself is a structure or not. Take, for example, the social withdrawal of autistic people. Once they get the diagnosis, they are so happy that they finally have an explanation for their being different. And then typically they often say, well, I've tried to compensate my life long, and now I'm autistic, and I stand by it. And and my social withdrawal is a structural phenomenon. That's me. I'm autistic. I don't go out. And then it's sometimes interesting to discuss this with the patient, because social withdrawal is not a structural phenomenon, but sometimes patients like to see it as a structure, because that means they don't have to go for it. And it's exhausting to change problem behavior, but it's important.
So many questions, and I don't think we have time to take all of them. So I'm going to request people to email me. I've put my email down into the chat. And, I'll certainly, if the questions are really burning, I'll also get Professor Ludger van Elst to help us with the answers. And also those who want to watch this again, it will be, the recording will be on the Buddhi Clinic YouTube page in a couple of days, so you can go back to it and see it. Ludger, two final questions for you. The one is, how do you explain amygdala hijack? What's your
amygdala hijack
as a theory?
You mean arousal attack, or what do you mean?
The whole concept that there is this control, as if your amygdala has been hijacked, and then at some point in time, the rational brain comes back into operation.
Okay, I know what you mean.
Yeah.
I personally think that these states are probably a kind of dissociative states. I think it's a disintegration of prefrontal circuits that are known to control amygdala activity pretty tightly. In particular, the circuits arising from the orbitofrontal cortex are well known to normally control amygdala networks. So that's isocortical or neocortical control of allocortical or limbic networks. And I think in these situations where you have, for example, rage attacks with an altered state of consciousness, it's probably a kind of dissociative state. And how this dissociation works, I don't know, I must say, but that's a mystery. But it must be able in a physiological way. I mean, that's what you basically do when you concentrate on something. When you concentrate on something, or when you focus yourself on a conscious problem, what you do is you focus different the functioning of different networks. You bind them together, and when you stop, for example, doing mathematics and you start talking with a friend, then you must deconnect some networks from each other and reconnect other networks from each other. The way how this works and who is in the central control of this business of connecting and disconnecting networks, that's, as far as I know, still a riddle. I mean, there are these like 19-year concepts from the 90s where they thought there's something like a central controller, some brain area that is in control centrally of this process of connecting and disconnecting cerebral subnetworks. I'm not aware of empirical data that show that there is something like a central neuronal network control, but I think it's kind of self-organized. And in these amygdala attacks, I think what happens is that probably for unknown reasons, maybe it's kind of paraepileptic mechanism, the networks that are normally connected to each other disconnect, dissociate, and that's why then the output from the amygdala to the brainstem is uncontrolled, and then you end up with like these predeformed brainstem behaviors, like with a cat. I mean, I think it's a little bit scary, this video with a cat, where you sort of stimulate the hypothalamus, and then you get pretty much preformed behavioral patterns, aggressive behavioral patterns. But it's basically brainstem and amygdala behavior, what you see there. It's totally disconnected from the whole cortex. And that's what I think happens in these amygdala attacks, that the control from neocortical top-down networks, in particular from the lateral orbital cortex, fades away, dissociates away.
So I think, all good things have to come to an end, and we could keep talking. I would sort of encourage everyone to think about how the brain has such a huge role to play in human emotion. And I think Professor Van Elst has today really highlighted that for us, the role of the amygdala and how it functions as our emotional brain. It takes me back to think about what Luria said, that it's either a limbic outflow that the prefrontal cortex cannot control, or indeed, the failure of the prefrontal cortex to control even normal limbic outflow. And I think I don't think those ancient theories have been disproved as yet, which is what makes behavioral neurology so interesting as a subject. So thank you, Ludger. Thank you very much for taking time off your busy schedule. We appreciate it greatly.
Welcome.
And of course, Namaste has become the world way.
Oh yeah. Now I thank you well as well.
Bye-bye.
Bye.